I don't know why you asked me to give this talk, but I won't take it personal.
I didn't make the schedule.
That's right. That's right. Thank you, Manny. Appreciate it. So thank you, sir. This is actually a fun presentation to put together because we're looking over some of the cases that we did. We were able to put a little dog and pony show together and look at a lot of cases to go through and look at how we tackled some of these issues. But with respect to TEVAR for dissection, there are modes of failure. There are early modes of failure, which encompass persistent 1A or 1B entry flow into the dissection plane, into the false lumen. A lot of this is secondary to entry tear ambiguity. And the reason is you're not quite sure where that entry tear is. You thought you knew, and all of a sudden you realize you didn't know after that first CAT scan or your subsequent arteriogram. Distal intimal disruption is another frequent flyer. So you can have disruption of that distal intimal tear from your endograft, particularly if you're oversizing in the acute setting. And then you want inadequate coverage. So for patients with rupture, we generally want to cover the entire aorta. And if you don't cover the entire aorta down to the celiac artery or thoracic aorta, you can make the patient prone for continued bleeding into the chest for those rupture situations. And then you could also misidentify the false lumen, where the wire goes in and out of the true and the false lumen, which is an absolute nightmare. But I don't have a case to show you about that, thank God. So you also have late failures, and this is the most common form of failure that you see at type B dissection, and it usually is aneurysmal growth, and we know that aneurysmal growth is seen in over 30 to 40% of the patients now treated with TEVAR. So we know the natural history of TEVAR a little bit better than we did yesterday. After the treatment of type B dissections, it's becoming more clear how some of these patients respond. We definitely see aneurysmal progression as an expected outcome in 20 to 30% of these patients treated. We know this for a fact now. It's higher in patients treated in an acute phase, and also mitigation of persistent false lumen flow in these patients is paramount for subsequent aneurysmal regression. These are a bunch of papers that are looking at diameters after TEVAR for type B aortic dissection. I look at both thoracic aorta and the abdominal aorta, and you can see that all of these papers show significant increases in aortic diameter for both of these areas. Abdominal growth is not reported heavily. However, you can see a 20 to 49% growth rate, 33% growth rate, 40% growth rate. So when you're done with your aneurysm or with your dissection, you'll know that surveillance is key ongoing. So the aortic growth and aneurysm formation is the reason for the majority of secondary interventions performed after TEVAR. This is the most challenging group of patients, in my opinion. The complexity increases with the chronicity, and there are various techniques to induce false lumen thrombosis and also favorable remodeling. Here's a case. So it's a 62-year-old male. He's status post TEVAR for an uncomplicated acute dissection, done at another facility. He comes back, transferred to us with recurrent back pain and chest pain. He also has neuropathic pain and left leg weakness. Here's his CAT scan. So you can see the TEVAR is placed, and it's kind of a short TEVAR, and all of a sudden you see pretty significant intrusion of the false lumen onto the true lumen. When we look at it closely, there's a large reentry tear adjacent to the distal endograft identified within the intima. This is one of those early failure modes that I just discussed. And also the false lumen had significant pressurization where you saw involution of the true lumen due to secondary to pressurization of the false lumen. And he had a small aneurysm already begun in the abdominal aorta. So we took him to the OR, and all we did was basically extend the distal endograft down to the celiac artery to take care of that fenestration. Here you could see, before we placed the endograft, you could see the involution of the true lumen. And then after we placed our TEVAR, you could see that pulsatility was clearly in favor of the true lumen and minimizing the false lumen. So this guy ended up doing really well. Now we have a 66-year-old female who had TEVAR for type B aortic dissection, which was lost to follow-up. She had, at the time of her initial surgery, we placed an Amplatzer plug in her very, very small false lumen, and I thought that was going to shut it down. Turns out the false lumen laughed at me. So she was lost to follow-up. Then she comes back about a year and a half later, and then you can see persistent false lumen flow. In addition, you'll see that Amplatzer plug right there. And then you see that the remainder of aorta basically looks like the garden variety type B aortic dissection. So the persistent pain bothered us a little bit. So we had a multitude of reentry tears distally in the aortic bifurcation. And I like treating that with a nice endologics device that sits really nicely on the aortic bifurcation and shuts all those little reentry tears down. So we started with that, got into the false lumen via a reentry tear in the left iliac artery, and then I start identifying all the outgoing vessels. So I want to individualize and embolize each one of those egress vessels, if you will. And you can see here we start, and that took care of that one, and there are a multitude of others. And then we ended up just, I call this mani-mataing the false lumen, just deploying a number of false coils into the false lumen. And subsequently, now that I know I'm finished, I want to close the reentry tear that we used as access into the false lumen. We do that with an ICAS stent, and that worked out really nice. And you can see here from our completion CT scan that the majority of our false lumen is completely thrombosed with the aid of selective coil embolization of those egress vessels. Here you see that again, that Amplatzer plug. That false lumen was really small when we initially treated that patient. Then it grew substantially. A lot of scatter from those coils. So secondary intervention for failed TEVAR is very common. We like to identify reentry flow targets, and then using covered stents, you can shut down those reentry flows. But sometimes I'd like to keep those reentry flows open so I can maintain false lumen access, particularly when I know I'm coming back in later on. And this is an example of an external iliac. This is the most common place that I get access to the false lumen is through a reentry flow in this area. Another case is a patient in for a second opinion. He developed a thoracoabdominal aneurysm secondary to a type B aortic dissection that was initially treated with TEVAR. The transthoracic aortic growth grew over 2 centimeters in 1 year, and the patient was declined for open conversion for a poor cardiac risk assessment. And here you could see a little jet of flow going into the false lumen, and this is clearly where this is failing. So nobody wanted to operate on the guy, but based on his CAT scan, it looked a little funny. Here you thought that maybe this endograft tore into the intima and generated a 1A leak. So in closer review, we shot a picture into the left carotid, and lo and behold, that's where the entry tear was, in the left carotid. So basically, we placed a Viabond stent graft at that level, and it shut down that entry flow completely. And that was all we did. And then the subsequent CAT scan shows complete thrombosis and regression of the aneurysm, in addition to some persistent false lumen flow distally, but we're still observing that, and nothing to do there unless he dilates later on. So that one little entry tear in the common carotid artery. Again, entry tear ambiguity is another reason some of these fail. Here's a 65-year-old male with progressive back pain after TEVAR for type B aortic dissection. He now has an aneurysm that's 5.3 centimeters in size. Just a quick run through of his aorta. You can see the aneurysm there. But when you look at it, he has a multitude of entry tears right at the visceral segment adjacent to the renal arteries. Here you can see here is his right renal artery. There is the entry tear for that. And then also, actually this is the entry tear for the left renal artery. And here you can see another re-entry tear in the celiac artery. So we were trying to figure out a way to do this without operating on the guy from an open standpoint because he had a poor heart. So we elected to use a fenestrated device. And here you could see we were able to get through the septum of the intima and intubate the left renal artery, in addition to putting together a nice stent graft solution for him that was minimally invasive. And ultimately, he did very well. Well, I could show you. I really want to show you. Here it is. As a CAT scan, you see that endograft. It's got a little bit of flow in the false lumen adjacent to the celiac, and that's because we didn't cover a big area in that celiac. There's still a small reentry tear. But again, it's something I can continue to follow, and if there's growth, only then will I embark on anything further. Again, endografts can be really useful for covering distal reentry flows. And here's another patient that had a multitude of distal reentry tears, and then we placed an endologics graft, and again, that shuts the whole thing down. We showed examples of direct false lumen intervention with coil embolization. Again, embolizing intercostals, stacking coils in the false lumen. This can be very helpful and induce false lumen thrombosis rather quickly, and once you create a static environment. And here's another illustration of egress vessels in the false lumen and coil embolization that basically shuts that down. There's also other adjuncts of false lumen intervention. We use Anplatzer plug for smaller vessels. We compartmentalize certain areas, and then you're able to do other forms of therapy like thrombin injection, if you will. And when we perform thrombin injection, we do that very carefully. Here, like in this instance, you want to be mindful of your entry tears. You want to make sure there's no visceral communication of the false lumen. We lose 10,000 units and 10 cc's of saline with a hint of contrast. And here you can see the injection, which it immediately produces false lumen thrombosis in that patient. And I use the Anplatzer plugs as sort of a barrier so it wouldn't go into the pelvis. And you can see here's the arterial phase injection, shows no more false lumen flow. So this was helpful because this patient had hypogastric aneurysms from his dissections bilaterally as well. So in conclusion, TEVAR does not eliminate the risk of aneurysmal degeneration. Early and late failures can be remedied by detailed imaging and entry flow management. Direct false lumen adjuncts are an effective tool in promoting false lumen thrombosis and all decreasing the risk of subsequent aneurysmal degeneration. Thank you very much.